Hi, good afternoon, everyone, or actually good morning to those of you on the West Coast. But welcome to our second general webinar of March, and today we have it on recommendations for surveillance of EMS data for opioid overdoses. So I'm very pleased to introduce Sylvia Verdugo, Mike Thompson, and Todd Stout from FirstWatch, who will be giving today's presentation, and we'll hear more from them in just a bit. But as people are signing on, I do want to point out a couple of housekeeping items. So all attendees are muted for our events. And at any point, if you do have a question, the presenters have indicated that they would like to take questions as they come in. So please feel free to click on the icon of the hand if you'd like to ask your question out loud. Otherwise, you'll notice in your personal control panel that there is a question box for you to type in questions and submit to us. So as you submit in a question, both me and the presenters will be able to see them as they come in, and hopefully we'll get them addressed as quickly for you as possible. And before we dive in, just a note about some upcoming ISDS events. Tomorrow we do actually have our next Overdose Surveillance Committee meeting. This will be from 1 to 2 p.m. Eastern Time. And this will actually be a great follow-up to today's webinar on using EMS data for opioid overdoses. And they'll even discuss further on some case studies on EMS linkages with other data sources for tracking the overdose crisis. Then next week, we have our next R Group for Biosurveillance meeting, the topic of which will be an introduction to R Studio tools for data science, targeted more for intermediate and advanced users of R. This will be Thursday, March 28th from 2 to 3 p.m. Eastern Time. And then leading up into April, our first two calls of April will be the Syndrome Definition Committee call on Wednesday, April 3rd, 1 to 2 p.m. Eastern Time. And we'll also have our next Spirit Committee Practice Exchange call on Friday, April 5th from 2 to 3:45 p.m. Eastern Time. All right, so that's all the announcements I had to share with all of you today. So thank you all for joining again. I see more of you are signing on. My name is Catherine Tong. I am the program coordinator at ISDS. And I'm very pleased to introduce our presenters for today. So Sylvia, I'm going to go ahead and give you the screen. And feel free to take it from there.
Great, thank you. So hi everybody, this is Todd Stout, and those of you who've been to the ISDS conferences over the last decade or so have probably seen me. A lot of what we do with ISDS is try to help people understand the value and utility of emergency medical services data for public health usage. It began obviously in the old days with biosurveillance, syndromic surveillance, and has really gone into so many other areas. One of the most common of which right now is overdoses in general. This is about opioid overdose data mining, but we found it in many places around the country that do not have an opioid overdose problem. They might have a spice or a K2 synthetic marijuana, meth, coke, or other kind of things. So a lot of this will be applicable to looking at your EMS data for opioid work in general. We'll talk a little bit during the presentation about our background and experience with it. The general intention of our company's work, we're a private for-profit company, been around about 20 years, but we really believe in doing the right things. And we have learned a lot about mining for opioid data, and we have committed to a project that this is really a launching point for, to make what we know about mining opioid data from EMS available freely on our website. So at the very end of the presentation, there'll be some URLs to go to. I'll also paste them into the chat window, and we encourage you to check it out later today. The specific information, this slide presentation will be on that site as well, and we will put the data mining specifics on that page and update it over time. I would encourage you to use it however you see fit as a starting point, or to refine your current processes for opioid. We think it's just such an important topic that it's not something that we want to keep to ourselves. We want to share our experience. With me, I've got Sylvia Verdugo, who works with us in a clinical and advisory role. Sylvia has, like me, actually all three of us have a background in EMS, emergency medical services, starting in the field and working in various capacities. Sylvia is also a doctor and has her MPH from UCSD in research, and we're super happy to have her. She's been the lead on this project all along, so she'll be actually doing most of the talking. We've also got with me Mike Thompson. Mike is a technical advisor here, but as well comes from the emergency medical services world. And if we have specific questions about data fields or things like that, we've got Mike here to back us up. So Sylvia, I'll turn it over to you.
Thank you. All right, so once again, another thank you for taking the time out of your busy schedules to sit down and hear us talk about opioid overdose mining with EMS data. And this is the overview for the talk. I'm going to be walking you through each one of these points very briefly. Don't get scared. And one of the beauties about talking to you lovely people today is that I really don't need to spend too much time talking about why overdose is important, why overdose matters, why it should be a matter or an issue of public health. So I'm not going to spend too much time talking about this, just trying to remember about these lovely maps. And it seems, well, to me, they're kind of lovely, kind of beautiful, especially these kind of like interactive, more fancy maps. And of course, if we tend to forget a little bit about opioid overdose, we also have all of the media blasting us with this sorts of news and headlines, just reminding us about the epidemic and the crisis. Now, for good or for bad, we generally receive morbidity and mortality overdose data, whether it comes from a clinical setting, from a hospital, or obviously the coroner's office. There is a steady flow of information. And this will be all good and perfect, except for the fact that if we only base our data in these two data sources, we are still missing a piece of the information. And this is obviously EMS data. So EMS data is particularly important in the cases in which a patient was assessed on scene but maybe refused care against medical advice. So it was treated on scene and transported. This overdose case will never step floor in a clinical setting and thus will never enter the count of morbidity in the clinical setting. Also, from us that have had the privilege to work on the field, we know that the EMS setting is special. And we generally can get very detailed, very robust data that we don't generally get otherwise. So we have the privilege of entering a patient's home, looking at their environment, meeting their family members, meeting their peers, getting a good glimpse of their living conditions. So while a regular female 45-year-old woman with chest pain, it's just that in a hospital or emergency department setting. In a pre-hospital setting, this female is also a woman that in her living room, it has a big picture, big framed picture of a young man. And under this big picture is 2 lit candles and a fresh vase with a bouquet of flowers. So when we gently ask this woman, who is this young gentleman on this picture? And she just starts bawling and lets us know that this is her son who died of a tragic car accident. And exactly this day, it's his 1-year anniversary. So that is kind of the power behind EMS data. And, this story about this 45-year-old woman is actually true. So that happened to me. And those are the little kind of skills that you learn along the way, like reading the pictures on the wall, as my office mate would say. So once upon a time, an EMS call. So this slide is aimed to tell you a story about really what goes behind every single 911 call. And of course, I'm going to tell you the standard classic version of, and the prince and the princess lived happily ever after in the castle in their enchanted forest. But in real life, there are, of course, some variations to this story. So everything starts with a person picking up the phone and dialing 911. So on the other end of the receiver, and I've put in here some pictures, of course, because this is a story. So in this picture, this dispatcher is a woman. So she is sitting right here in front of her desk. She has 5 screen monitors with displaying different kinds of information. She has a headset in which she is communicating with the caller, the 911 caller, and she is trying to gather as much information as possible and ask the correct questions to kind of get a glimpse of what, the problem is. Why is this person dialing 911? Where is the correct address? She's making decisions of what would be the appropriate EMS unit to send, how many units need to be sent to the location. So while this is all going on, you need to also remember that on the other side of the receiver, this 911 person that accesses the service, she's probably, he or her, having, one of the worst days of their life. There's commotion, there's hysteria in the background. So this dispatcher has a lot of work to do, and I really don't envy their job. It's one of the things that I absolutely never could do. I would be horrible at it. So this dispatcher needs some help. And it does get a little bit of help, and there's a system that we call CAT, that's a computer aid dispatch. And what it does is that's exactly it. So it's a computer software that helps this dispatcher navigate through all the questions that she needs to ask, that helps her attach timestamps, helps her dispatch the appropriate units to appropriate location. So she does get some relief out of that. There's also an additional system that we call EMD, and that's an emergency medical dispatch. So there's another kind of names for the same system that you may be heard. So it can be also heard of, EMD determinant, procure determinant, procure code. So they all kind of are related to each other. And this system is basically a set of guidelines and rules that will help guide the dispatcher, again, into making a classification of the nature of the problem. It will walk her through each of the questions that she needs to ask to assess the patient. Assess breathing. Does it have a pulse? If needed, do we need to start CPR? If it's choking, check for airway. So all the different little steps that the dispatcher can aid while the units get to the scene, this is one of the systems that helps her with. So once the dispatcher does her lovely work and, the ambulance arrives into the scene, where it be, a fire truck or, a BLS, a basic unit, and advance a flight unit, wherever the case may be, once the ambulance gets there, then the work of the dispatcher is done. And now here, the clinical team now needs to assess the patient, provide treatment, and transport it appropriate. And of course, they need another data source to capture this. And this is the EPCR, which stands for Electronic Patient Care Record. So there is a story behind every 911 call. And there is obviously more than one data source attached to this 911 call. And while we usually always notice EPCR because there's clinical data attached to it, we always need to take into consideration that there's also this dispatch system, CAT and EMD. So if we are really committed into doing opioid overdose surveillance based on EMS data, we need to take into consideration that there's more than one data source. And then we need to take into consideration a basic question. So this question has kept me up at night for several years. And it's a question that really bugs me, and it's a question that sometimes makes me doubt every piece of information that I see regarding opioid overdose. And that is, what the hell is an actual opioid overdose? What's the case definition? And after attending ISDS, I was very pleasantly surprised to know that it was not just me. So it's not just me asking this weird question. There are other people that are asking the exact same thing. And while there are some guidelines and recommendations to establish case definition in opioid overdose, it is not standardized. And that's kind of the thing that bugs me when I talk about morbidity and mortality. So what are we actually measuring? What you are measuring is not the same as I am measuring. So how are we going to compare data? So in our FirstWatch world, this is again another map. As you can tell, I'm really into maps. I like visual data. We work over 4 million. 40, sorry.
Yeah. So I'll just jump in. This is the part I added in. So part of what I want to explain is the reason we think what we're saying has value to people is that we look at, for the last 20 years, public safety data, mostly EMS, emergency medical services, and 911 data in real time. So we process about 40 million public safety records annually, over 110,000 a day, through our system in real time. So we do lots of things. Opioid surveillance is one of them. We do that for about 500 agencies around the U.S. and Canada, and our customers actually serve a population that's equal to about 37% of the U.S. and Canada. So we've seen lots of data. It's very dirty. It's very non-standard. And what we're going to show you is really the results of our experience that are able to inform, so you're not starting from scratch because there's just no reason to.
Okay. So thank you.
Sorry.
Thank you for that. So taking into consideration this cumulative wisdom and also thinking about that some of these agencies, the people that work behind these agencies have a ton of experience in EMS, have been working in EMS for, longer than some of us have been alive. So we can't just ditch all that. That's wisdom behind it. So during some preliminary analysis that we did to all of these data sources, we found that FirstWatch had already built a little bit under 200 triggers that made reference to overdose. About 3/4 of them made relation between opioid overdose. And when I mention trigger, that would be kind of like our term of, a case definition. So it's a set of filtering criteria what determine if a 911 call is an overdose, yes or no. And we can attach a time series or time analysis to it. So taking those, a little bit under 200 triggers, we started collecting and analyzing, all of them, and we started to find things that each one of these triggers had in common. So we started making a list. So again, taking into consideration the different data sources within EMS, we started with our CAD system, that's a computer-aided dispatch, and we found that chief complaint and problem, as well as the free text search in the comment, were very common within these 200 triggers. From the EMD data source, we found that a ProQA determinant, ProQA code, or ProQA card, whatever you want to call it, was also very important to look at. And from the EPCR version of it, we saw that provider impression, intervention or procedures, vital signs, and narratives were, again, another item or data elements that we should take a look into. So once we had these kind of data elements, we went back to our original data and started doing some data mining. So with CAD, specifically on the data element of chief complaint, what descriptions do we need to take into consideration to form this sort of master opioid overdose case definition? Well, we needed to include, of course, a chief complaint that talked about overdose, ingestion, or poison, a person that was labeled as unconscious, and within the dispatch comments, we needed to do a free text search. And once we hit EPCR data, I'm going to talk a little bit more about this keyword search. So that's from the CAD side. From the EMD side, we needed to look for an EMD determinant, again, or ProQA code or card, whatever you want to call it. And we're looking for a card of 23 or 31. And a code 23 makes reference to an overdose, and card 31 makes reference to a person that's unconscious or man down. And you notice that we added in here a wild card. So we don't really care about what comes after, as long as this code starts with 23 and 31. And from the EPCR side, we're looking at a primary and secondary impressions that had to do or had some relevance with poisoning, overdose, unconscious, or altered mental status. Now, I know, or we know, that you speak fluent NEMSIS code, so I took the liberty of adding there a little box with the translation of, NEMSIS language of what corresponds to this, for example, right here in primary impressions. So that would be situation 11 and 12, and we included the ICD-10 codes corresponding to these descriptions.
Can I break for just a second? Did you get a chance to talk about what NEMSIS is?
No.
By chance? So for those of you who are not aware, you can get the data directly from the electronic patient care record system provided by your EMS agency's vendor. But there is also a national standard that the federal government has worked on for a long time called NEMSIS, NEMSIS, and that is very standardized. They're on a version 3.4X right now. It changes slowly over time, but these are codes that specifically relate to that. So if you have access to your EMS provider's NEMSIS data, then you can go in and use the actual field that we're identifying directly. If not, you can go find the corresponding field within their electronic patient care record application and database that ultimately feeds this NEMSIS data. But we're trying to be as specific as we can to save you the trouble of having to find this information.
Thank you. Very well. So moving on to interventions or procedures, we are, of course, looking for an administration of Narcan. And here we really don't care if the Narcan was administered by the crew or it was administered prior to arrival, and thus the reference to medications 2 and 3 from the NEMSIS code. So as long as Narcan was administered by anybody, for a bystander, a peer, police officer, first responder, we really don't care as long as it was administered. So those are the two references for the NEMSIS codes. And we also wanted to learn a little bit more about the patient and the clinical side of it. So we're looking for vital signs. So what translates into a person that's having an overdose with vital signs? So of course, we need to take into consideration respiratory rate. So we're looking for a decreased respiratory rate that we labeled as being under or equal to 12, and an altered mental status that we identified as a Glasgow Coma Scale of less than or equal to 13, and we have eVitals 14 and 23 for the NEMSIS code. And lastly, on the free text search in the narrative, we have a very long list of keywords. We have 126 in total, and this list we came up from a previous research study that we did in collaboration with the University of Reno and UCSD. So this very long list, I took the liberty of breaking up into categories to kind of give you a glance or a glimpse of what this keyword list includes. So for example, we included 100 words that have something to do with prescription drug names, sorry, whether it be generic or brand names, and any common abbreviations or misspellings. We included 17 substance or medication use reference words. We used 5 words that had to do with heroin and overdose, and 3 words that had some reference with intravenous drug use. And lastly, 2 slang words, and here we use dope and sellout, which are the most common words to talk about opioid overdose slang. So, we have all our 3 data sources. We have all of our data elements. We have all of our descriptions. So now I want to show you a couple of examples of opioid overdose triggers or more sort of case definitions that we have built. So I'm going to show you 2. The first one is this trigger that we can, quote unquote, call highly specific. And I've broken it down by color. So for example, the green components or the green criteria make reference to CAD data. The yellow component makes reference to EMD ProQA determinants or codes. And the kind of pinkish reddish make reference to EPCR data. So I know it looks a little bit complicated, but it's basically measuring 2 things. From the dotted line up, we are basically looking for documentation of opioid overdose. So we're looking for a problem or a chief complaint in the CAD that is looking at poison, at overdose, intoxication, or we're looking for a ProQA determinant that has to do with a card 23 or 31, or a primary or secondary impression that again has to do with anything related to overdose, unconscious, altered mental status, or man down. And along with each of these documentations of impressions and problems and such, we add an and statement that is looking for a free text match, either in the CAD comments or in the EPCR. So it's basically looking at, okay, give me all the possible documentation or reference to overdose and in combination with a free text search. So that's what the first portion is actually looking at. From the dotted line down, it's saying, okay, if you forgot to put in documentation of overdose or make any reference, fine. Let's look at the patient. So what kind of patient are we looking at? We're looking for a patient in which Narcan was administered, by who we really don't care, as long as it was administered. And we're looking for a patient that had an altered mental status and that his respiratory rate, respiratory rate was decreased, and also proved to me that the Narcan worked, right? So we're looking for an improvement of altered mental status and respiratory rate or pupil response post-administration of naloxone.
So, thanks, Sylvia, for that. The way I like to think about this and why we have 2 different approaches, the highly specific approach or the more sensitive approach, is it really depends on what you're trying to do. Many of our customer agencies around the country are working with local task forces, and they're often doing some kind of an intervention with the overdose patients. And so with those interventions, you have a limited number of resources, and you want to really boil it down to those patients that you are certain were actually an opioid overdose. And you also want to do some things outside of this, like I want to not necessarily respond to an overdose or reach out to somebody who's an overdose at the jail, or maybe you want to do that. So is really trying to get to that idea of, if I have a limited number of resources to work with and I want to find those opioid overdoses for sure, then looking for the fact that Narcan worked or this other approach is a good use for it. So I think that's kind of important. I think the other thing that we'll get into a little bit as we go is it's really important to think about that Narcan administration as where that information is coming from, as Sylvia said. So whether that Narcan was administered prior to arrival and that information is in the dispatch comments, whether that is in the electronic patient care record comments is administered prior to arrival. There is, in most electronic patient care record systems, a field for medications administered prior to arrival. Then there's medications that we administered, meaning that the medic, then some medics will put it in not as a medication, but as what they call an intervention, and other times it'll just be in the narrative. And so to do a really good job at this, you have to look in a lot of places, and there's a great amount of opioid surveillance work going on now where folks unfortunately just don't realize how dirty the data is and where all they have to look, and they think they're getting good counts when in fact they're missing quite a few opportunities.
Thank you. So this would be our, highly specific, highly complicated kind of, taking everything into consideration, opioid overdose approach. Then we have another example that would be a highly sensible, again, clinical. So in this kind of like trigger or case definition, we are again looking for the same kind of components. We're looking for documentation in either the problem or chief complaint in the CAT or appropriate determinant within the EMD system, or a primary and secondary impression in the EPCR. And here we're looking again for very basic things. So Narcan administration, alter mental status, and decreased respiratory rate. So kind of like a milder version of the first example that I just showed you. And we started doing some initial analysis on these set of case definitions to not just, provide recommendations, but also, provide some input and provide some information and data behind it. So these are all different triggers that we have built out for opioid overdose that we have measured. And we, made a very basic analysis to it, sensitivity, specificity, predictive values, and likelihood ratio. So nothing out of the ordinary. So from the two examples that I just showed you, the closest ones that were, approximate to the analysis that we did here would be OD1 and OD2. And as I see, our numbers are not that bad. Their specificity is really high between these two triggers. We still have some work to do on the sensitivity, but all in all, trigger OD2 is looking pretty good. So we're still doing some additional analysis to it and additional tweaks to assess the sensitivity issue here. And this is, an exact copy of the table results that we presented on, the poster session at ISDS. So for our future steps, what do we intend to do? We need to do more analysis. So along with, the basic analysis that we did, we are trying, or we want to kind of cut down the components of our case definitions. So for example, if you only have access to CAD data, or if you only have access to EMD data, or you only have access to EPCR data, we would be able to provide, along with the recommendations that we talked about, all the fields and descriptions that we are looking into, but also attach there, this basic analysis about sensitivity and specificity and, predictive values and such. And a second tier to that would be not only provide analysis for each individual data source, but also provide analysis for each individual variable. So for example, if you only have EPCR data, what is the weight value of just looking into primary and secondary impression? Or what is the value or weight of just measuring, altered mental status in the vital signs? So provide a little bit more complex and more robust analysis to these recommendations that we are talking about today. And all of our information we will make sure to be posting and make available to you. These are the different links that will tag to all the information. Any new data that we come up with, any new analysis, we'll be sure to post it.
Yeah, and you can see the information up here. I'll go ahead and while Sylvia is choking to death over here, I'll go ahead and jump in. So again, our intention is for this information to be a good starting point as we evolve it over time, as we learn more, and as we do more research on it. We'll post that as well. The specific page on our site is listed there for those of you that are only on audio. This will be available for the recording later, but it's www.firstwatch.net/finding-opioid-data. And that page will be specifically updated with this information, including the lists of free text words and things like that. We'll try to provide as much information as possible to make your task of looking at EMS data as easy as we can. Also, it's pretty important when working with your EMS providers, I believe, that you understand their world and what they do. I strongly recommend that you go sit in the dispatch center of your local provider, understand how they do it, what kind of things they're faced with. Sometimes it's frustrating for public health and other statisticians and analysts at the dirtiness of the data. And frankly, once you sit in the dispatch center and realize what happens when things are busy, when they're dealing with all kinds of issues and what they're faced with, it makes the non-standardness of the data understandable and frankly much more tolerable. And if they'll let you to actually ride along in the field and watch and see how things go, I think you'll be fascinated by it and give you the same perspective on the field data as well. To see without having to do all that and learn, you can also go to our page, firstwatch.net/HI for health intelligence/opioids. And we've got a lot of different posts on there and articles and links that I think can help make things more understandable. And if you like what you see there and you'd like to be updated when the health intelligence page section is updated, you can actually sign up for an email update when those things are done. That was really our presentation as we went through it. We've got our contact information here on the screen, and we're really delighted to help, whether that's by email or by phone, as you're going through there. This is an important topic. As folks at ISDS know, we're kind of ridiculously evangelistic about the value of EMS data and the value even more of a good, solid public health connection with your emergency medical services and 911 departments within your community. I think we have time for questions, a lot of time for questions, and I've been handling some of them on the screen now. You can, as Kat said, you can actually post your question here. You can raise your hand, and I think Kat or I can unmute you, and we'd be happy to go ahead. Any questions that you have?
Great, thank you so much, Todd. Thank you so much, Sylvia. So we do have a hand raised, but Todd, after this, maybe we can go through some of the questions that were typed in and submitted to us via chat and speak them out loud, for the benefit of the audience, the other audience members to hear. All right, so first, Julia Hood, I see your hand is raised. You've been unmuted.
Hi, thank you. Thanks for a great presentation. For the sensitivity, specificity, PPV, and negative PV, NPV, what were you comparing your algorithm to? Like what gold standard?
I know you very well, and I knew this question was going to come up, so I have a slide for it. So, gold standard, in quote-unquote gold standard. So we did a couple of different things to come up with a sample of EMS data in which we knew what an opioid overdose was, yes or no. So what we did, and this was the first initial research that we did for the University of Nevada, Reno, and UCSD. So the first thing that we did is take a full year worth of data from an EMS agency that was willing to participate and share their data. And we filtered out every, call that would absolutely have no possible way of being an opioid overdose, right? So for example, obstetrics, right, or trauma, or something that was really out there. So we took all of those calls out of our data set. And then we reviewed, and we did clinical review, 1 year clinical review of the data, and it was a little bit over 29,000 calls. And then we did another filtering attached to these 1 year worth of data, in which we were looking at an improvement of respiratory rate, pupil response, and outer level of mental status once naloxone was administered. And from that group, we did 100% case review. And then the second tier would be any call in which Narcan was administered. And again, there we did 100% review. And then we were left with this very big chunk of data that just included keywords. So from this big chunk of keywords, we did another layer of filtering criteria, again, trying to take out or actually take in all calls that had a problem, a primary impression, or anything that could be related to overdose. From those, we took them out, and from that, we did 100% code review. Then we did an additional random review of 200 calls. So from the very first tier up on the very, very top, we took 50 random calls. We reviewed them to make sure that we were not missing any probable overdose calls. And then from the second layer of, keyword search that we did, and then, we put the additional filtering criteria, we did a random check of 150 calls, again, that did not fit the criteria, and just kind of like to prove that we were not missing any data. So that's kind of how we got to this gold standard. It is not perfect, but we did, code review, clinical code review to most of these calls. And then again, to get into the values of sensitivity, specificity, and such, the data that I showed was the complete data set, the complete year worth of analysis, but we also checked in half. So we did run the analysis first from January to June, and then to July to December to compare that, that our numbers were not off. So, and they were, pretty close. I think 0.3 or something like that. They were off. So that's kind of where we got the gold standard from.
Great. Thank you, Sylvia. So I'll just start through the questions that have not been answered yet, and then if we have time, we'll go back through, as Kat suggested, the ones that have been answered. One is Howard Borkham asks, why is high sensitivity a difficult challenge with these data? How good do you think sensitivity could be given the data quality? What's your thought on that, Sylvia? I would say why it could be a challenge is because of the quote-unquote dirtiness or non-standardization of the data. Some of the other questions down the road help make it clearer, too. There are sometimes when the patient is dead on arrival, and so things don't happen with that. So I think there's a fair amount of work. But, Sylvia, what would you guess at how good do you think sensitivity could be?
I think from what we have worked so far, it's just a matter of playing around with the filtering criteria. So we've never, this has never been done before. There is no marker of reference. So right now we're in the process of just playing around with it, for ANTs and ORs, put it in, additional criteria, taking it out. I think we're in the process of actually figuring that out. And, we'll be happy to tell you once we figure it.
Yep, and we're happy to get feedback from anyone else. And in fact, if you have information to add that you think makes what we're putting on the site better, we would love to get that and include it. Also, if you have approaches to your data or ways that you're making improvements in opioid overdoses or deaths in your community, we'd love to have you submit it to us as well for inclusion as a resource on the site. And of course, we would point to you or whoever sends it as the way. Nasser said that they have looked at the names that are being recorded when naloxone is being administered. I think that you mean from the perspective of different ways to refer to naloxone and Narcan.
Yep.
So that is certainly great. We are happy to have that shared if you have different versions. And I think there are also, as we find in general with free text surveillance, different systems around the country use different terminology for different things, and sometimes conflicting terminology depending on what you look at. And so EMS data is local in nature, and I think that's one of the challenges for somebody like Howard, who's looking at data across the country in various places. Trying to understand the local aspects of it can be relatively tough. Keenan from Washington, D.C. asks, how confident are you in detecting overdoses not involving naloxone?
So again, there's not a single approach to determining opioid overdose. So, one of the tiers does look into naloxone administration, but again, we have documentation of overdose within the different data sources, and we have keyword search. So there is a lot more to identifying opioid overdose that goes beyond just Narcan administration. So that's, I'm sure when we do the analysis, it's going to go up high with regards to sensitivity and specificity. But it is not the only way we should be identifying overdose. There's a lot more things to be looking at.
Great. Nasser provided a little more information. I have looked at the names that are being recorded when naloxone is administered. There are almost 20 different names. Mm-hmm. Why is this happening? And I think, all I can really tell you is that is the nature of EMS data. And it's just you can spend a lot of time with your EMS providers attempting to get them to document things in a standard way. And if there is a lot of focus, you can get improvement for a while, but over time with turnover and as people's attention shifts away from it, the data will become dirty again. And so we think it's smarter to spend the time building, for example, all those 20 different ways of looking at it and always watching for more than to spend a bunch of time trying to get people to document accurately. The EMS people and 911 people did not go into the field to become excellent data enterers. They went into their fields to help people and to get things done and in their mind save lives. And it's hard to get them excited about documentation. Harold Collins asked, what are the specific questions to be answered by the data collection and analysis? A great example is people will do it from a like we have an agency in Trinity, Massachusetts that is really heavily affected by opioid overdoses. And they use these kind of analysis for work, looking in real time at overdose deaths or overdose calls. And one of their case studies, besides doing interventions after the fact, they look for evidence of children in and around an overdose, pictures on the refrigerator, things like that. And they will notify Child Protective Services to come and check on that child because they've had cases where both parents have died of an overdose and nobody knew that there were children there. But one of their most interesting things to me is they've had very successful use of when they get a statistically significant increase in those overdose calls, they actually have a system and a process for posting that information on social media. So they have had 2,000 views within minutes of Facebook posts in their communities, basically saying, hey, is a bad batch of stuff out there. If you use, don't use alone, and if you know someone who uses, please check on them. And they've actually, anecdotally, there hasn't been research done on it, seen a decrease in those calls. So that's a couple of use cases. Another question from, I hope I say it right, Bozina, is have you thought about excluding instances where opioids and Narcan are administered by EMS responders, i.e. that this response was not in response to an opioid overdose? I'm not sure I understand the question, Bozina. If you can clarify that further. I think from our case, whether the opioid, I guess the opioid wouldn't be administered by the EMS responders, but if it was something for a pain medication, perhaps you mean. So perhaps you mean something like where a morphine or something has been given for pain and it was an overdose. That's a great example where you could definitely leave that out if it was administered. And certainly, I'm sure there are cases in EMS where certainly there are cases in EMS that where someone does administer an opioid for pain purposes and could have given more dosage than they should and then does give a Narcan administration. That'd be a great exclusion as they go. We actually, for Montgomery County Fire Rescue in Montgomery County, Maryland, we actually have a process where we exclude that. So really good. So I'm going to go away from some of the questions that have been asked, and then Kat, do you want to open up the microphone for people that have raised their hands?
Sure thing. So we just have 2 people who've raised their hands, but Peter Hicks, you've been muted.
Hey, Todd, great presentation. Really appreciate it. I'm going to squeeze in 3 questions because I always cheat. So can you give a little bit of background? I always cheat. A little bit of background on some of your data architecture. Is there a standard data model? How do you move data around? Is it you're using HL7? Is there a central repository, or is this at least a network of local repositories that are queried? As you said, it's really about the local response and what's happening rather than national trends. And then I got a couple of questions about analytics.
Okay, so in the first place for that, so that's one of the hardest things about doing surveillance across multiple sites is you really have to just get the data however you can. So in many cases, like the Lowell, Massachusetts agency that I talked about, we literally connect directly to their local electronic patient care record database, querying the tables and fields that we need for it. We move the data securely via XML across to our data centers, and then that's where all of the analysis and alerting and this kind of work is done. Agencies that have a hosted electronic patient care record system, which increasingly they do, each hosted vendor tends to have a different format. Some of them, thankfully, have moved to the NEMSIS 3.4 format, and they'll send that. Part of what's a challenge with EMS data, even with the NEMSIS format, is that some of the agencies will bypass the standard places to put this information. They'll say, oh, opioid monitoring is super important for us, so we're going to create a user-defined form with user-defined fields to make it easier for our guys and gals in the field to enter that information, not realizing that by making it easier for the folks to enter the information, that unless the people that are surveilling the data understand where it is, you're just looking in the normal places, but you don't realize that that it's actually great data, but sitting in some user fields. So it's very much about understanding the underlying data, which I think after years of going to ISDS is really the generally good information for surveillance all over. But in our case, then once we bring it in, we keep it in close to its in native format so we can do more work with it, and then we homogenize it for purposes of comparison across organizations. Does that make sense?
Yeah. So are there, do you receive free text and coded data, right?
Yes.
Okay, and then the analytic question, I'm really glad someone asked the gold standard of like how you're getting your PPVs, because that was the first thing that jumped to me. Do you weight some of your queries? So do you make certain terms have more of a value? Does that make sense?
We have not done that yet, but that's a good idea. I think as we get more research and information in there, it will, but we have not thought about the weighting factor.
Yeah, and then another idea is including negation in your Boolean operators. That might also help sensitivity and specificity.
Yeah, and I think we do that certainly in individual and specific triggers. We're looking for those words, and then as you said, the negative versions of those as well. Our free text uses a combination of regular expressions, which really make that a little easier to do, although more complex.
Right. You might be interested. I'll share this with you when I get online. The definitions that we're using over here in syndromic surveillance, and they're moving along pretty well. And some of the groups here are using them. That might be
we'd be honored.
And likewise, we'd like to see yours. Thanks a lot, Todd.
Thank you. Go ahead, Kat.
All right. So I see Andrew Broadway. Your hand is raised. You've been unmuted.
Hello? Sorry, is it my turn?
Yes.
Okay, thank you. So my question mostly revolves around some of the dirtiness of the data. Like you said, I noticed that for my data, the chief and primary complaints are very much open form. So there's not any really coherent way of categorizing it without manually going through 10,000 records. I guess what I'm asking is that do you think it would be sufficient to categorize opioid overdoses by complaint to dispatch, naloxone in administration, and whether the patient improved or not alone? Or do you think I should make a more restrictive category?
So I think in our case, it depends on what we're trying to accomplish, right? What you're trying to find, what's the question you're asking. But it's a pretty good question to say, I want to find all the patients that got naloxone and got better afterwards. So I would say in most cases, I would be fine with that, with maybe the caveat that the previous person asked the question about related to what if the naloxone was given because an accidental overdose of an opioid was administered. And so I think it really depends on the scenario for how you're approaching it. Usually, when you're doing an intervention type program, you're going to have other criteria as well. You may focus on that plus a geographic component. Maybe you literally only have people to respond in certain areas of the community, and so you'll limit it further by that. And so I think a lot of it comes down to your resources and availability and your tolerance for missing things versus including things. And that's why we're sharing both the sensitive and the specific approach. Does that make sense?
Yes. Thank you very much for the charts with the sensitivity, specificity, et cetera. That's tremendously helpful to me. So
great. Thank you.
Yeah.
Thanks very much. Yeah.
All right. So we have one more hand raised. Howard, I see your hand is so you've been unmuted.
Todd, Sylvia, can you hear me?
Yes, sir.
Hello.
Okay. Hi, Sylvia. I really appreciated your opening with showing the special perspective that the emergency technician has. And one observation is that the naloxone is amazing at keeping the habitual user alive from one overdose to the next, but doesn't do anything in its own right about preventing the next overdose. In fact, it makes some users more or less concerned about putting themselves at risk again. And I'm wondering, have you had any thoughts about how these data could be used by health departments or other organizations to help prevent the next overdose? And if you've even thought of things like having technicians use their judgment to dispense naloxone, expecting that something else, that another overdose could occur.
Those are great points, Howard. So we definitely have agencies that are having us watch for patients who get multiple calls to them where they receive Narcan or naloxone. So in order, to sort of look at those people that we're seeing again and again, to have a higher priority. So from that perspective, people are definitely looking at that. And I think, there are, I don't think I know, there are certainly agencies within our customer base and others that will go one step further, and they will have the medic document specifically either in the narrative or some other user field that, explicitly it is an overdose to make this task simpler. So, as you deal with each community, understanding and talking with their training officers, understanding and talking with some of the medics to see that's where they're right along and watching it all happen, watch the documentation happen really helps. But at the same time, it's kind of like, syndromic surveillance monitoring, and, in the old days where there would be a drop-in system where somebody had to enter extra information to make that happen. And that happens with, irregularity based upon each individual doing it, their level of motivation to do it in the first place, their motivation to keep it up, 3 o'clock in the morning, 15th call in the 24-hour shift. Do they remember to check that box? But it gives you one more place to look to say, hey, if the medic said this was an opioid call, then that helps me find that call in the first place. So it's a great idea. It's just none of these things are bulletproof. It's the combination of them that has the power, we believe.
Mm-hmm. And then there's,
Well, yes.
there's also a couple of agencies that do go that extra step and have community paramedicine programs that will actually go back into the scene in which they, another unit attended an opioid overdose. They go back, they have, information available about substance use treatment. They have rooms available for people that want to enter rehab. So there is agencies that are taking a little bit step forward than just identifying opioid overdose.
Well, to just follow up on the subject of controversial ideas, where do you stand on safe injection sites?
Howard, you're not going to like my answer because I need to disclose that I was trained in all matters of overdose by anthropologists and sociologists. So I have certain terms embedded in my brain, like, overdose victims, along with my please and thank you. So I've kind of been trained in the more tolerant. But that's just my personal view. And, I'm all for drug injection sites. But that is just me, my personal training and, background.
Thank you. Thank you. That's a more common answer than you might have thought.
Yeah. Oh, great. And is there any, Kat, shall we go through more of the written questions now?
Sure, yeah, why don't we do that, and then we'll go back to some more hands.
Okay, great. So let me start at the top of the list, and thank you, Howard, for taking some of them off the list for us. Let's see, Sylvia mentioned there'll be future work going through CAD, EMD, and EPCR separately. Been able to examine how the trigger algorithms perform for dead on arrival overdose calls that may not have complete information in EPCR, for example. And before you answer that, I'll say there was another question related to that, which is where somebody pointed out that the data that we have available is really complete, whereas data that goes to regional, state, or national level NEMSIS that has a decreasing subset of information. So the question is, if you have limited access to data, then have we done any work to identify what the validity of these kind of tests are? So I would simplify it to say, if I only have dispatch data, how helpful is it? If I only have primary and secondary impression and I don't have the underlying comments or narrative because it could contain patient identifiers, how would I do that? And to be honest, other than what Sylvia will be able to say in a moment, we haven't really done any of that because we've been focused on helping the individual agencies with the data that they have, which in our case, we're lucky that we have it all. We're HIPAA business associates of these agencies. We're providing lots of different kind of data analytics and business intelligence kind of solutions and services for them. And so we're really focused on doing the most with what we have. It's a great question. And as we do more work, and especially if we're able to work with some agency that could get a grant or something, then that will be a great question to answer. Anything else beyond that?
No, I agree. That's an excellent idea. So, along with the future research about weighing individual data sources and weighing individual filters or descriptions or criteria, that's a great idea. Just look on dead on scene, EPCR records or such, and look at the validity of those. So that's amazing. I wrote it down. I'll be sure to take a look.
Great. Harold Collins asked, what is the expected effect on overdose outcome expected from the recommendations derived from the analysis? So, I can just go back to a couple of different agencies that have been using this to get good information. In most of the joint task forces that our customer agencies participate in, this is the only real-time data that they have that has a lot of information about it. Even if they have real-time hospital data, it seems to be difficult to get that out of the typical hospital data that goes for syndromic surveillance. So, this really has informed a great many different initiatives. I know at least they're working on some research so they can publish it, but I know that anecdotally we're told that the folks in Trinity, Massachusetts, for example, Lowell, Massachusetts, that they have definitely reduced, last I heard, by about 50% overdose deaths Now, to Howard's point, it didn't necessarily reduce the overdose calls, but it has reduced the deaths from those calls. And somebody else mentioned about giving, leaving Narcan at the scene. And I also know some of those Joint Task Force initiatives involve that, whether that's officers leaving it or the EMS staff leaving it. In many cases in the EMS world, the only times I know of where they're leaving Narcan at the scene is where there is a community funded initiative, because the EMS providers don't get reimbursed for leaving Narcan at the scene. And Narcan, naloxone is very expensive, and they often are worried about running out, because if it's a fentanyl overdose or things like that, it can take many doses of Narcan to do it. So I don't know of any EMS agency leaving naloxone at the scene unless it's part of an overall public distribution method, because that is funded by some kind of community grant or something like that. And then we have a question, Sylvia. What does the T1, T2, and T3 stand for? Is this associated with each data source stage in the opioid overdose process?
So T1, T2, and T3 are kind of the same as OD1 and OD2. So there are different filters or triggers that we can build with different combinations of, and or statements. So T1, T2, and T3 are actually triggers that we build along with the University of Reno and UCSD on this first tier of research.
And then, thank you, Sylvia. And then Julia Hood asks, are you aware of any agency and or jurisdiction following up with individuals who received EMS assistance for suspected overdose? Yes, we mentioned a few on our opioid resource page. If you can go back to that URL site, please. On that opioid resource page there are some information about that. We also have a matrix of about 4 or 5 different agencies and different approaches that they take for that. And you can also email us directly, and I can try to get you in touch with some, especially if we know of any in your community. Kat, do you want to do any hands raised for a bit?
Sure. We just have one hand raised for now. So Nelson, you've been unmuted. Hi, Nelson.
Yeah. Hey, good afternoon. Thank you so much for an excellent presentation. I would like to know, though, if you do have denominators for all of those parts of the country that you covered, wherein you'll be able to calculate rates for this health condition, and then we'll be able to see if the rates that you found in those areas are comparable to what other national data have shown, or something along that line.
So let me try to restate your question. It was a little muffled. So I think you asked if we have denominators or sort of counts of the overdoses by different areas.
Yes, those that you all have to cover. Yes.
I'm sorry?
Yes, the areas that you covered, yes.
We do for each individual agency the process. We're getting ready to roll out all those 200 or so triggers, as we call them, that we look at overdoses within the community, have all been built, kind of over time, specific to the each individual agency's needs. And so we're actually getting ready to roll out what we refer to as an opioid overdose network. We have had, for example, a regional influenza network amongst our customers for quite a while, with a standardized set. And so we anticipate increasingly having people use this sensitive or specific or both approaches, in which case we would then be able to have meaningful denominators. And then once they agree to participate in the network, then at that aggregate level, we could share that data with other members in the network. That's how our regional influenza network works. Does that answer your question, I hope?
Yeah, to some extent. Anyway, you probably don't remember. I mean, we used to meet at APHA conferences several years ago.
Oh, good. Very nice to see you. Thank you.
Yes.
Oh, great. Thank you. So, Kat, how are we doing on time?
We are doing great. So just a note too, the entire audience. So this session does go for another 25 minutes. So I know a couple of you have to drop off now, but the webinar is being recorded, and I believe Sylvia and Todd will be sharing their slides with us. So yeah, so we still have another 20.
Okay, great.
Yep.
Great. We have a number of other written questions that I'll just kind of power through, and then feel free to ask more. Do you have access, meaning us, do we have access to the CDC Essence data system? We do not. We've actually had a couple of requests, both from folks agencies who have their own regular Essence system, and then more recently from the very first one that we have that uses the CDC Essence system. So, I have reached out to Mike at that to talk through how that might be possible. A lot of people want to be able to compare their different data sets, and I know with the regular Essence system, Wayne Lotion and I have talked for a few years about how we would push EMS data into the Essence system for agencies that have FirstWatch to make that process smoother. And Wayne and I are ready, just really waiting for an agency who has FirstWatch available and the Johns Hopkins Essence system to do that. So if you're interested in that, please let Wayne or me know. You can go back out to the contact page. Thank you. We'd love to do that, but I think getting connected to the CDC Essence system would be great. Mandy says, in Indiana, there are many efforts to create response teams to do home visits to check on folks and offer services. So that's an area that, to answer one of the questions, was in Indiana. There are lots of them. And I think that's happening a lot. I think places, are realizing that, giving a lot of Narcan isn't necessarily helping the long-term problem. And even those folks that have the task forces and things, one of the biggest issues that I've heard is that they have to have access to getting beds open in facilities when that person is ready. And different agencies take different approaches. At Richmond, Virginia, for example, EMS works with law enforcement there. They've worked through the HIPAA issues, and the next day after an overdose, once the patient is either discharged from the ER or did not go in, as often happens, it's another aspect of the EMS data that's important. Many people are awakened with Narcan and refuse to go, so there's no hospital record at all. And in Richmond, Virginia, they actually send a narcotics detective to the house of the overdose patient with the idea that people might be more inclined to say yes, they'd go get help with an officer there, and they think that works very well. Other places have said, no, we have better success with paramedics or firefighters or a team of medics and social services people to go out. So there's a lot of people trying different things to go through that. Somebody asked how you can get a copy of the presentation. We'll be providing the handouts for CAT. We'll also have them on the website that we have listed before here, and ISDS will have a recording of it as well. Let me just make sure I'm not missing. So one says, do you consider in-hospital ICD-10 data for transported EMS patients to assist with building the gold standard? That's a great question.
Yeah. So I'm actually working right now, this moment, into building, a similar set of case definition or filtering criteria that goes along, CAD, EMD, EPCR, but also linking it to emergency hospital records using ICD-10 codes. So I think we have one or two agencies in FirstWatch that have the entire set of data. So that's actually what I'm working right now, and that's a great idea. Also to incorporate that, I'm trying to incorporate that in meeting or achieving gold standards.
Yeah, that's really great. And then I will say, Mandy, who mentioned about in Indiana, there are many efforts to create response teams, do home visits to check on folks. Mandy, Autumn Roach has asked the question, said she would like to know what programs in Indiana follow up on overdoses. So if either one of you want to reach out, or both of you want to reach out to us or to Kat with your contact information, we'd be happy to connect you two together so you can go through that. The only customer we have in Indiana right now is in Fort Wayne, and I'm not aware of any program that they do with that. Nicole says something that I'm not sure I understand, and perhaps if you're willing to, you could raise your hand, and we could unmute you and you could explain. But she says, please shut down this anti-harm reduction approach with evidence. Thank you. Do you understand?
Of course I do.
Oh, okay, go.
So, yeah. So anti-harm reduction, you can go either way. Either you like chocolate or you don't. So it's one of those things that you feel very passionate about, either pro or for it. And there's a lot of evidence behind how harm reduction works. In the overdose setting and the substance use setting. So I understand exactly the question and where she's going to, and I agree, and I'm with you.
So I see Mandy has given her information. So Autumn, if you'll stick with us until we get a chance to send it to you in the chat window, we will share that information, Mandy's information, so you can reach out to her. So thank you so much, Mandy. Let me make sure I've got everything. And then, Kat, while I'm doing that, I think we had a couple more hands raised.
That we did. So I see, Andrew, your hand is raised again. I believe you're still unmuted. Hi, Andrew Broadway.
Hey, on the topic of like trying to follow up with patients who overdose, we're sort of doing a preliminary thing like that in South Carolina, and it's been pretty iffy. But I'm hoping that some other states have a better success than we've seen with our preliminary. A lot of people refuse to actually talk with the people who come. So, but yeah, that's really all.
Andrew, great. That's a great question, and that's actually I'm really glad or comment. I'm really glad that you said it, because that is an area that I hear, at least anecdotally, quite a bit about why people are liking the EMS data and how specific and timely it is, because it's allowing them to target people within a community. And I say target in the best possible way. I have heard, for example, that they will often work a neighborhood on purpose, and they will not just talk with the people who overdosed yesterday, but if one person in that neighborhood dies of an overdose, they find, and again, this is all anecdotal stories that I've heard, but they find that most of the time that the users in that neighborhood are aware of, or maybe even know closely the other users. And so they will actually reach out to people that they've identified before who wouldn't talk with them after an overdose death in the community. So because they're looking for any opportunity, any trigger, any motivation to say, well, you wouldn't talk with us before, but and now HIPAA doesn't apply anymore because the person is dead, is how they approach it. And they'll say, Bill, Bill died yesterday of an overdose. So we really don't want you to end like Bill, and they'll go through it. And so having access to that information over time, having access to it geographically, they have mobile units running around that will specifically only be told about calls within the area that they're serving, because they're really focusing, like marketing, their attention. If you're marketing, you see multiple ads before you buy. You get multiple opportunities before you engage a lot of times, and I think that's what they're seeing here.
Yeah, thank you.
Great.
All right, thank you, Andrew. I see, Nicole, your hand is raised. Do you have a follow-up question?
Hi, can you guys hear me okay?
Yeah.
Okay, so I think I understand the analysis table. By the way, great presentation, you guys. So the T1, 2, 3, and then OD1, OD2 correspond to your triggers. Is that correct?
That is correct. So each one of those, label T1, T2, all of them represent a single trigger. So a single set of criteria, looking at all, across all data sources with different and or statements that we've done some analysis to determine which one is more useful, if you may.
Okay, so a couple of follow-ups. One was on the presentation, I'm only really seeing 1, 2, 3, 4, the highly specific, highly sensible, and I can't, and maybe I'm missing something, but I can't correspond with which one it is, but it is interesting to see the sensitivity of 4% for T2, and I'm wondering if so somebody could be given a Narcan, and I'm thinking maybe it's a Narcan one, the administration, and then there's an improvement. And are you guys capturing ODs that are not? This is for non-fatal, correct?
Right.
Okay. I was just curious about which one the T2 corresponded with, so you could maybe find where in that sequence there's the where you're losing the sensitivity. And also, I'm just also curious too, that because this is fantastic, and the sequence of like what I would call a case lifespan of the data sources, from dispatch to potentially arriving to the hospital, is how this might also influence the codings, right? So you said something about a assisted technology of the dispatch person to ask those specific questions. It might be that you might want to make changes to that given the lack of the sensitivity or specificity or something like that could inform future policy. Just some thoughts.
Right, that's an excellent idea. Thank you about that. We're going to take it into consideration to move on forward. Thank you.
Yeah, I think this is really, I would say, been a little bit of just to meet the needs of the individual thing. We're not a big fancy company with a huge amount of profit to do a lot of research. So we're sort of lucky to be able to do what we can. But I think as more and more people are involved, we'll be able to do more. And that's what I hope to do with that opioid network. Miranda Chan asked the question, have you tried using natural language processing tools to detect overdose events? What tools are you using to analyze the data in general? So regarding natural language processing, we have not. And I think it's definitely a lot of opportunity to do that. We're really using, regular expressions and specific matching and a variety of tools that we use throughout it. From a tools in general to analyze the data, we are using, either custom functions that we create using SQL Server, Microsoft SQL Server functionality. We recently were lucky enough to bring on a part-time data scientist to kind of augment the approach that Sylvia takes, and he is in the process of connecting kind of the R functionality that's available within SQL Server. So we'll be using more R-related things for some of our initially just research and internal research and understanding, ultimately as part of our trigger building and other process. Thank you for that question, Miranda. I think we've got everybody's question answered either directly or live. So I'm going to go to the ones that were answered in the past really quick and make sure that we can show that. Let's see. We had how do we find the presentation? We talked about that'll be on the site, and Kat will send that out. One person said, do you need to have all of the indications of improvement, meaning, the altered mental status, respiratory rate, and pupils to determine that it worked? And no. My answer was, it really depends on how specific you want to be. Everything you do that is a requirement reduces the number of times, not necessarily because it was not an improvement, but either because it wasn't documented accurately, or that aspect of patient's care didn't improve. Now, Sylvia, from a physician and EMS standpoint, what was your thought?
Well, if you're going to impact both of them. If this is really an opioid overdose and you're using naloxone, then you're going to get an improvement of respiratory rate and altered mental status. Will the person be, completely conscious? Well, maybe, depending on the dose and, the amount of drug that they use. But we will see an improvement on both if, it's a true opioid overdose.
Great. And then Ridgely Fix asked, what is the ProQA determinant? What NEMSIS field is it in? And this will be part of what we put on our webpage. But for those of you that are looking for it right now, it's edispatch.03 is where the ProQA determinant field goes. So all of that information will be in there. And again, if as you look at it, once we get it posted later today or tomorrow, if you have some confusion about it, please let us know, because if you're confused about something and we can make it clearer, we'd love to, and that'll help everybody. I don't see any new questions as we go through this. I don't see any hands raised. So, Kat, I think we're in pretty good shape, unless anybody has any last-minute questions. Or if I didn't answer your question, please raise your hand, even if you don't have audio, and that'll help me look to find your question in the list. We had quite a few.
Well, right as you said that, I saw Howard's hand go up. So, Howard, I believe you're still unmuted.
Oh, I just unmuted myself. Can you hear me again?
Yes, sir.
Todd, I want to go back to when I've heard you speak before. And in the past, you've said that among emergency technicians, there are some who may not necessarily take accurate data recording and data entry seriously. You've mentioned conventions and that sort of thing. Given what's going on with the overdoses, is that culture changing?
That's a great question. I think I would say in organizations that have culturally communicated well, it's changing. And what I mean by that is, I don't think most people, not just emergency medical services people or 911 call takers, most of us go to work to do a good job. I kind of tongue-in-cheek say we don't go to work to suck. We go to work to do a good job. We go to work to help people. And, organizations that either don't focus on accurate data or rather spend their time focusing on getting data accurate so they can bill and make more money, because even fire departments and government third services bill, and it's often a huge part of their ability to provide services, don't have a lot of buy-in from the folks that are there to help people. It's a lot of public health agencies understand this really well. You didn't go into public health to not help people. You went in to help people, and I think EMS people as well. So a lot of it has to do with explaining the value of the work. So to answer the question kind of specifically, most EPCR questions do have a validation score, or what they call closed call rules that must be met to submit the electronic patient care record. Few of them, though, are specific enough to be able to say, if it's this kind of call, you have to do this. If it's that kind of call, you have to do that. And so it's really an ongoing challenge. It's actually one of the things that HIDA has a really cool program called OD Map. That's an app for people's phones. That the idea is if you go on an overdose call, you're supposed to open up the app, put the information in. It logs the geographic location, and you can do it, which is a really neat idea. The challenge is you've already got these EMS staff or public safety staff that often are feeling like they're over paperworked already. They are already doing too much work, and they've already put this information into their records management tool or their electronic patient care record tool, and keeping those folks focused on, now let me pull out my phone and double enter information is awfully tough. So we've actually got agencies that are having us push the dispatch and electronic patient care record data, into OD Map, so that OD Map can be more and more specific and useful without actually requiring double work by the staff. But it's a really great question, but it's really an ongoing problem because it's not just opioid. If we're trying to talk about STEMIs or strokes, childhood, pediatric asthma studies and work, and I mean, there's a million things where having good data helps, and so it's really a cultural within a department by department basis. And frankly, there are still a lot of department heads, chiefs, and EMS leaders that have been around a long time. We didn't need data before. If it ain't broke, don't fix it. And so I think this will also get better over time, just as people retire and people that are a little more oriented to data and know that having good data helps will work.
Thanks very much to both of you. It was very valuable.
Thank you,
Howard. Quite happy to help. Any other hands or questions?
Hey, Todd, yeah. Really? Any other hands?
Okay. We really appreciate it. We're very, very serious about wanting your input. If you have EMS specific things that you want to have shared, we're delighted if you send it to us, email. We're delighted to put it up there. We're thought of by a lot of folks, including within the EMS world. We're sort of a hub. That health intelligence page is sort of a hub for translating. If you go there, you'll see things in there related to, everything from Ebola to Zika, and we try to take what's happening in public health and in related health issues and translate it to a very specific, what does the EMS need to know about this? So we have a lot of EMS folks that go to that site. We're happy to also have it be a place where a lot of public health people go to learn about using EMS data as we do it. So anything we can help with, we're happy to. Anything we can help share, we're more than happy to. We thank you for your time and your work. I tell people at ISDS all the time, I love hanging out with public health folks because they remind me a lot of the EMS people I grew up with. They're people who generally are trying to do good work. They're really not well understood. They're rarely paid well. They often have way too much going on, and you really do what you do because you care, and that's how we feel, and we thank you so much.
Great. Thank you so much, Todd, and thank you to your team as well. So Sylvia and Mike, thank you for being on today.
Thank you.
Thanks, folks. Have a great day.
You as well. Thank you, everyone.
Bye.